Dr. Campbell?
Yeah, so my practical question is, do you calculate the creatinine and do the formula before you do your challenge test?
Yes.
Then, so you've got, you know how much EDTA, just based on your basic challenge, then from a practical perspective, how do you do it? Do you have the patient sit in the office for 6 hours and wait to collect? Do they take the test kit home and send it from home? Practically speaking, how do you actually do that?
Well, assuming somebody has a normal creatinine, I don't do the ratio. I had a 93-year-old guy with a creatinine of 2.7, and I did it with him. He actually came down to 0.95 eventually once we cleaned out his tubules. But I keep the people in the office for about 2 hours, send them home with a kit. It's all self-explanatory in a little bucket, you know, they send the stuff in.
Okay, that's fine to make a diagnosis of heavy metals. But when do you make a diagnosis this person doesn't have heavy metals?
There's a problem.
I use the ratios. I do a challenge, and I look at my baseline, and I look at the post-urine, and if there is not a significant elevation, I would say to them, it looks like there is not a significant problem. However, toxic metals hide in many other organs, and sometimes we cannot pick it up. It depends how you respond to my program. If you don't respond, we'll look for it again.
So in other words, even when you cannot demonstrate heavy metal, you will still treat to see if the patient responds?
No. I will use other modalities. You know, I will not chelate them, or at least will not be my first choice.
But there's also, as you said, if mercury is 0.5 and it goes to 3, from your perspective, it is significant. So that's why I'm trying to have some sort of consensus. And then also, teaching is also that one test may not show anything. You have to do repeatedly to show. So that's what I'm saying, to have some sort of consensus when one should say, really, person doesn't have much heavy metal. So just with one test, can you pretty much say that I'm going to go to other modalities and not treat heavy metal just with one
Not
test?
with mercury.
No.
And unfortunately, people have impaired detoxification pathways, and it doesn't show up. It depends on the symptom. If you know, it's nice to have rules, but medicine is still an art. If you have a patient in front of you that you just get that feeling, they're sick, they have a problem, they're fatigued, they've got other problems going on, and like she said, Jeanette said, you'll just you'll use your other modalities, you'll be using your diet, but then you might come back to
the example patient that I see a lot is a perimenopausal woman who may have issues with estrogen, progesterone, and maybe hypothyroid, may have fatigue and so on. And she also just recently had her mercury removed. And so for them, at least in Canada, they don't like to spend too much money. And private insurance doesn't cover for many of these testing. So it's easier to tell the patient, which of you, it doesn't show a significant retention right now. Let's modify your diet, let's improve your hormones, let's see how you feel. If you are not feeling to the level that you are supposed to, then I think we need to recheck you again.
I'd also like to comment.
Because one test is not enough.
Tipo, I'd like to comment also that EDTA doesn't just take out heavy metals. I was involved with the 19 other clinics in the country for a 2.5-year study back in the mid-90s, looking at the coagulation the coagulation benefits of EDTA, and we did comprehensive coagulation testing before and after every 7th chelation treatment for 2.5 years, and we gathered thousands of data points. And we showed unequivocally that EDTA is a powerful antiplatelet drug. And when we sorted through all of the data, there were 3 markers that we could use that really dependably identified if a patient was forming clot or plaque at the current time. One is a fibrinogen level over 400, one is a serum calcium over 10.0, and the third one is an LPA greater than 35. Well, most people who have LPA greater than 35, it's not very easy to change a genetic marker. The calcium can be controlled by chelation, and fibrinogen goes up and down depending on how inflamed one is. All 3 had to be present. 2 out of 3, you wouldn't be forming clot at the time. But we didn't publish the study, by the way, the results of it, because we concluded that had it been published and applied for FDA approval for EDTA as an antiplatelet drug, it would have likely been approved, and in being approved would have likely assigned a limiting charge to it, which would have been less than what it took to administer the therapy, in effect killing the treatment availability. Curiously enough, the data was all held in an office in Cincinnati, and the Fraud and Death Administration raided the office and confiscated all the data, and so it's not available anymore.
Dr. Mason?
But let me just make one further comment on Tipu's thing. One other thing, Tipu, if somebody has, SNPs, absent GSTM1 or P1, a couple or three abnormalities there, they tend to underestimate their urine output when you do a provocation, so that can give you a false negative.
Okay.
Thank you. Dr. Mason?
Yeah, I use the 6-hour urinary challenge test in testing my patients. And occasionally we'll see some patients with relatively high leads that after several chelations may end up showing up higher leads. They get upset about that.
So that's good.
What do I use to calm them down is I explain to them that in the past, radio-labeled chromium EDTA was the gold standard for determining glomerular filtration rate. And what's happening is they're getting a better filtration rate, and they're just getting more lead out, that their kidneys are improving, and that makes them feel better. I always keep one of the old articles on the kinetics of chromium EDTA, filtration rate determination. Today, the estimated glomerular filtration rate based on creatinine is so rough that people are in big trouble before their GFR starts showing up bad. The other thing that I've always worried about is that inductively coupled plasma mass spectroscopy is exceptionally sensitive, and it picks up aluminum from the IV fluids we're using, I do believe. Everybody I challenged, they're usually somewhere in the midpoint of the yellow range, the doctor's data's graph.
For what? For what? Aluminum?
Aluminum.
What are you using the challenge with?
We are using EDTA, calcium EDTA.
That's your problem. It's contaminated.
Yeah.
It always is.
Huh?
It always is.
Calcium EDTA is contaminated with aluminum.
Sure.
So why would you use it? Why would you put aluminum into your patients? That's my question. I mean, that's the thing I was...
Well, the other opportunity is use magnesium or sodium EDTA.
Yeah,
and
you can use that.
Equally too is contaminated.
Pardon me?
It equally too is contaminated.
Not with aluminum.
And if you're going to do that, you're going to have to get it in a diluted bag of IV fluid that also contains up to 25 micrograms per liter of aluminum. So you don't put aluminum into it anyway.
I don't see that because I can consistently, I was having high aluminums, and then when I found out there was contamination, I switched over to the disodium, and I put the bicarb in the bag, and I challenge with that. I get no, aluminum in a normal range.
Are you that concerned about aluminum as a toxin?
Pardon me?
Are you that concerned about aluminum as a toxin?
Well, I don't know, but I don't want to put it into them.
Well, it's third most common element.
If I know it,
so I mean, we better be,
If I know it, I don't want to administer.
I worry about
Can I
the
get
patient
the
with
other
renal failure.
members also to give their opinion, Dr. Bernhoff?
Which part?
In regards to the aluminum contamination and...
I was unaware of the aluminum contamination, so I'm going back to the drawing board.
I just saw a study
Yeah,
coming
look
up.
at package inserts on bags of water.
I haven't seen it, but I don't do calcium EDTA either. I only use disodium and magnesium.
Well, I use some calcium EDTA, and I think it has to do with the manufacturer too, how they compound it. I get it from the pharmacist, and I've been purposely looking at the aluminum levels in the patient, and depending on which brand you get, you may get a contamination. The other thing too is that I think we need to be worried about aluminum in regards to the potential risk to the brain as well. I mean, it's the most abundant, and you don't buy cake mixes and things like that because of aluminum contamination. Yeah. But we also know that there is a risk of neurofibrin damage similar to Alzheimer's.
Well, nothing else, there's probably going to be a synergy between aluminum and the other heavy metals. So, yeah.
Pardon me?
I said there's likely to be synergy between aluminum and the other heavy metals.
If you ask your pharmacy for EDTA to ask them, for their check, what they checked, and they ran it through an independent lab, all they're required to check for is lead. They don't check for all the metals. Yeah. So
Dr. Adams.
One of the things that I use, and I think I got it from Ted Rosema about a century ago or so, is a page out of a Health and Human Services booklet that has the listings for mercury, lead, arsenic, and cadmium. You may have an excess body burden if you have any of these symptoms. And so I will give that to my patients, and I will instruct them, be truthful but liberal. And it's got every symptom you can imagine in there. And I tell them they can be repetitive, but that is my proof of my index of suspicion that they might possibly have an excess body burden of heavy metals, and they've circled it in their own handwriting. And so that starts the first step. And
So do you test and do you do a provocative as well, or you
oh,
use
yeah.
clinical?
I'm just saying, I do this Mickey Mouse part because if someone says, well, man, why did you do that? Provocative? Well, because they indicated here in their own handwriting that they've got these symptoms, and that might be associated with an excess body burden of lead. And so that starts and then do the other things you guys mentioned.
What's the document you're referring to? What document?
Dr.
Certified knowledge from the Health and Human Services, and I don't plan on mentioning it, but I'll try to find it.
So, Dr. Adams, it would be nice if you can maybe give us that information, and then I can announce it to the later on with the.
I'll try to find it.
Yeah, that
If
would
I
be
could
nice.
comment on that for a second, I just published a literature search on mercury in the Journal of Environmental and Public Health, and the published symptoms associated with mercury go on for quite a while.
This is the Reader's Digest version.
All right, well, this is a peer-reviewed thing, that if you need that for any purpose.
That's
don't-
even better.
Don't forget the study that Shulak published in 1978 showing that the synergistic toxicity between lead and mercury was a 100-fold factor. So the first place you want to look for heavy metals is their mouth.
Yeah.
So that comes to my question: do you chelate with EDTA anybody that has mercury fillings?
Absolutely, because it does not leach mercury. I will not use DMPS or DMSA with that, because I actually had one patient, a woman who had fibromyalgia, and she had 12 mercury amalgam fillings, and I thought, and she couldn't afford to get her fillings out. So I said, well, I'll go ahead and give her DMPS anyway. After 12 DMPS infusions, like 2-3 weeks apart each one, she went to her dentist, and the dentist was aghast because it looked like somebody had been eroding her fillings. Actually, DMPS and DMSA will partition to the saliva and will dissolve your fillings. I'd rather have the dentist take my patient's fillings out than pee them out through their kidneys.
Dr. Hickey?
Probably for 4 or 5 years before I learned to use DMPS, I used EDTA, both forms, and DMSA as my provocation. And I showed this data at the iMosaic, but I was shocked to see the difference between urinary excretion of mercury and fecal excretion of mercury. There's so much more fecal excretion of mercury, to the tune of some patients 15 milligrams per kilogram, 80 milligrams per kilogram with minimal microgram excretion in the urine. So I really find that for 3 metals, if I don't do fecal, and again I did pre and post urine and fecal analysis initially, and found negligible amounts of anything, so I actually stopped doing the pre. It's nice to have that medical legal thing on your side, but I never found any substantial amounts of metals in the stool. I've gotten to the point now where if I'm looking for mercury, for bismuth, which is extraordinarily neurotoxic, and tungsten, which again is extraordinarily neurotoxic. I find it in all my ALS patients, my Parkinson's patients, my Alzheimer's patients, my fibromyalgia patients. If I don't do a fecal metals, I completely miss it. And the amounts are in milligrams.
Thank you. So the next question, do you load patients with any antioxidant during treatment, and what type of combination antioxidants do you use? And I'm going to add another question for the sake of time, and how do you prevent re-exposure?
Well, I try to find out what the exposure is and address that. I've noticed that increased amount of aluminum in the last couple of years in patients' hair, and I really suspected it may be coming from the sky, all this chemtrail stuff they're spraying up in the sky. I could comment on that individually with you if you want. I did an interesting study on that. But the other agent I wanted to mention was OSR, which some of you may be familiar with, the oxidative stress relief, Dr. Haley's product, which was taken off the market 2 years ago. But I treated about 400 people with OSR over the course of 2 years. And I believe, I just actually met with Dr. Haley and had a chance to spend 2.5 hours in an airplane with him last Sunday when we came home. And OSR now is headed off to Europe, and it has been already approved or listed on the European Drug Agency's list of orphan drugs, and by the end of the year he thinks it'll be available through a European source where we can just write prescriptions and we can send it over there and get it. OSR is unique. It's all now, the new name for it is NBMI, and it's got a long chemical name like EDTA. I can't repeat it. But it's going to be, it will be available, he thinks, at that point. It's the only agent that actually will partition into the brain and will remove, it is fat soluble, it goes into the brain, pulls mercury out and excretes it through the bile, so there's no toxicity to the kidneys. It is incredibly safe, and there's no agent that can remove mercury like OSR can remove it. And I've done numerous patients where I've tested them up and down after they've been on extensive OSR therapy, and they just don't find mercury.
And when you use the OSR, which nutrients are you watching for?
There's no depletion of any essential minerals with OSR.
Actually, there is.
Well, we haven't found it.
Because I had the opportunity to use, and there is molybdenum deficiency.
Well, molybdenum deficiency can pre-exist and can make people sensitive. So I always put people on molybdenum before I'd put them on OSR, because molybdenum, since OSR is a very sulfur-rich compound, we saw about a few patients who developed some side effects from it. So we just put people on molybdenum beforehand, and we avoid it.
So which type of antioxidants do you use?
Well, I put people before I give them the first EDTA, DMSA infusion. I give a meganutrient infusion first, before we even do the first challenge test. And when we do chelation, every 6 IV is a meganutrient infusion.
Includes what?
Pardon?
Meganutrients includes what?
Well, it's just a wide mix of minerals, and it contains some free amine and all kinds of B vitamins and just the kind of things that...
Would you be able to share the formula with us?
Pardon?
Would you be able to share the formula with us?
Well, I'd be happy to. I just don't have it with me now because it's a long list.
And which oral supplements do you give in between treatments?
I use, of course, vitamin C, vitamin D, vitamin E, fish oil, and multi and a probiotic. I consider those sort of foundational supplements in this day and age.
Jim?
Yeah, I do replacement of calcium, manganese, zinc, molybdenum, multivitamin,
Essentially the same. The EDTA recipe includes vitamin C, and between chelations we do a lot of oral minerals, include glutathione with many people.
Yeah, I give glutathione. To every IV, I give 1,000 milligrams IV glutathione at the end of the IV.
Okay.
Yeah.
So I guess this is the end.
If I could comment, I want to just share a brief case. I handed out a case report for y'all, and this case is a 50-year-old man who was juvenile onset diabetic. He got him on the Bernstein diet, Richard Bernstein's book, Diabetes Solution, probably the best book written on the topic of diabetes. And he was so compliant. How many type 1 diabetics do you guys have seen who keep their hemoglobin A1C consistently under 5? Well, and he had deformed, he had a deformed foot, just a Charcot-Marie tooth, a foot deformity. He ended up fractured his ankle and in his foot and ended up with a cast. The doctors put a cast on it, and they took the cast off. You can look in the first page of that. This is what his foot looked like. And the surgeons wanted to do an AK amputation on him. And I thought, this is the worst ulcerated foot that I've ever seen. I thought, what are the chances of saving this man's leg? Well, we decided to chelate him, despite the fact that his creatinine was consistently in the mid 2.5, around 2.5 range. But we did 2 treatments a week, and we did frequency-specific microcurrent therapy daily with him at home. We did low-level laser treatments twice a week, and he had excellent wound care. And after, you can see the progress of the lesions, but his foot healed up completely. And I just wanted to encourage y'all, if you see something that looks like this is impossible, what are the slim chances of saving a man's leg? Try it.
I'd like to say one thing before we leave. Beware of gadolinium.
What?
Gadolinium. Gadolinium is huge, and the research that's coming out on it, they've been putting it in people's bodies for 25 years with MRI dyes, and patients are coming in since the doctor's data started testing for it and getting high gadolinium levels, and there's articles where it can induce heart disease, and so just start to beware of gadolinium.
I think the significant problem with gadolinium is nephrotoxicity and systemic fibrosis.
Right.
I've seen neuropathies. I have one patient with chronic Lyme disease that was just non-responsive to everything, and she's doing really well with chelating the gadolinium. I just want to make a quick comment that I can't even remember which lecture I heard this in, but I always use glycine both in the EDTA bag when I'm doing a provocation, and I have the patients always take glycine like 500 milligram, depending on weight. 3 to 5 caps a couple hours before they get an IV or before they take an oral DMSA. And I also always give glutathione. We give the push at the beginning of the bag instead of at the end.
Well, I agree with that, Robin, and I've done the same. I had the glycine.
It does help the excretion.
I had the glycine, and at 40 milligrams per kilogram, and Uracit K, potassium citrate, 20 milliequivalents, which alkalinizes the urine, protects the kidneys. And after doing that, it increases the yield of heavy metals by about 30%, is what I found.
That's been my experience. And like you, the Connecticut Medical Board frowns on DMPS, so I'm limited to using DMSA in provocation. I'd prefer to use the DMPS, but we have to be careful of that. And oddly enough, there's been a lot of discussion about the pre and post issue. We do pre's now because I think that it's a prudent thing to do. Interestingly enough, that was not one of the questions that the medical board had with my charts, is that I wasn't doing pre's. So for what it's worth, all the emphasis on medical legal, that wasn't one of the things that they have a lot of issues with the provoked test, but not with whether you did a pre and post. So just FYI.
Why does it take so long to heal that foot? It was over a year. Is the chelation that slow, or? Well,
you can only chelate according to the Cockcroft-Gault. When you had a creatinine at 2.5, remember there's a limited amount you can give him, and the fact that it could even save his leg, I think that's pretty miraculous with a leg that looked that bad.
Yeah.
But it normally takes 20 to 30 chelations to deplete minerals. Why is it so slow? Is it just so many in there? Or?
Well, yes, it's poor circulation to start with. You're not delivering that much into the tissues, and it just takes a long period of time.
Is there something you could put in to make it go to the tissues better? Or?
Well, I don't. If I knew what that was, I'd have added it.
Some people use DMSO, right?
We didn't use the DMSO. I quit using DMSO when one of my nurses got really sick whenever we used it, so I just quit using it.
Because of the odor?
Yeah, it made her sick.
Do you use any DMSO?
No.
Do you use? So thank you very much for your participation.
Just one question, just one comment. You might be able to increase EDTA to the site using hyaluronic acid. This is something that really falls.
I should have thought of that. I didn't, because I have used that in the years past.
And how do you add it to the solution?
Yeah. You just add it to the solution. You can go up as high as 15 cc.
That would have been a good idea.
Yeah.
Could you get the same effect with something like oral lumbrokinase or something?
They usually, when you have a vascular disease problem, if I have a patient come in, I usually tell them 60 treatments of their age. That's the only rule I've ever heard in chelation. And so if they're 75 years old, 75 treatments is what we're looking at. So that's why it takes a year. It's just the nature of the beast, but when you save somebody's foot from getting cut off, or their leg.
Well, I think the other lesson with this fellow is that even though a diabetic maintains perfect glucose control, the microvascular complications of the disease march on.
There was actually a paper I saw about 6 months ago that the tight control had a higher mortality rate.
Yes.
Yeah.
So have your pizza,
Thank you very much for your participation.